All right, it's 2 minutes after. We're going to go ahead and get started. Thanks everybody for hopping on here. We really appreciate it. If you haven't already done so, please use the chat to introduce yourself and for attendance. Again, your name, your email, your organization and credentials. We've got a didactic presentation from Laura Lander and Anna Butcher, and they're also got some cases mixed in there as well. So hopefully we'll have a great discussion. Feel free to use the chat with any questions, raise your hand, whatever is easiest for you to do. And if you can turn your camera on, I know it's lunch, but if you can turn your camera on, that's great. If you can't, totally understand. But I'm going to throw it over to Laura to get us started.
Yeah, we don't mind if you're eating. I don't actually find it distracting. I love presenting to faces rather than names. And as you guys know, ECHO is supposed to be interactive. So Anna and I do not mind if you interrupt us along the way. We can look at the chat and Jay will help us monitor the chat. Also, if you have questions or comments along the way. So I am Laura Lander. I'm social work faculty in the Department of Behavioral Medicine and Psychiatry. So welcome to everyone. And Anna, you want to introduce yourself?
Hi, everyone. I'm Anna Butcher, and I'm the Urgent Family Response Coordinator. So I primarily work between behavioral medicine and CPS.
So Anna is really the expert advocate. So I'm kind of along for the ride, but she does, this is her primary job, is advocacy with CPS. So we're going to talk a little bit about what that looks like and then present some cases that she and I have worked with together. So Amanda Newhouse and I run group therapy for our pregnancy code group. So that's medication-assisted treatment for pregnant and postpartum and parenting women. So this is the population that most often runs into issues with CPS, although not always. But that's kind of our basis for a lot of our work that we're going to talk about today. All right, I'm going to share my screen and then I will get myself set up. All right, can everyone see that? Okay. So we're specifically going to talk about the ways in which we advocate for patients with substance use disorder with CPS, but we're going to kind of do some broad strokes overview first. So what is advocacy? Advocacy is defined as any action that speaks in favor of, recommends, argues for a cause, supports or defends, or pleads on behalf of others. And we know Child Protective Services and that system is a very difficult system to navigate. So it's different in each county depending on kind of the culture of that county. And we've had the privilege of meeting with some of the managers from different counties, and they've even talked about, oh, well, that's not how we do it in our county. Even though we're working with very similar cases, it's really different. Everything from like drug screening and how people do that to the judges that are in that county making decisions about parents' visitation to the prosecuting attorneys. They're all involved in the CPS system in which our patients are trying to figure out. So advocacy is a huge need. And why do we need it? Really to ensure that individuals' rights are safeguarded. Sometimes patients don't know what their rights are, and so we can help them know what those rights are, especially with regard to, say, medication for opioid use disorder. It is illegal and against the American Disabilities Act for them to be told you need to come off medicine in order to get your kids back. Like that's illegal. They cannot be told that. But we know that patients have been told that, or it's been implied, which is a little bit more difficult. So that's like one example of where we really need to help patients know what their rights are and then be able to advocate for them. Also offering support and inclusion. Sometimes patients feel really excluded from their own MDT meetings. So the multidisciplinary treatment team meetings that occur usually monthly when someone is involved with Child Protective Services, often patients will talk about, like, they sort of feel like they're a bystander and everybody's talking about making these decisions about their lives, and they're not even like included in the conversation. And so as an advocate, I know what Anna does is she both provides a voice and welcomes them into that conversation to make space for their voice as well, because patients are often afraid to speak up, or they feel very shamed or stigmatized. And in doing so, we really help create an more equitable power dynamic. I mean, it's never entirely equitable in the context of Child Protective Services. CPS and the court system has the power, but we do try and, as part of advocacy, empower patients to see where they have their power. They have the power to, if the concern is substance use disorders, which it often is to engage in treatment, to work on their recovery to the best of their ability, to abstain from substance use to the best of their ability. That's where their power lies. Show up for visits. Those are the kinds of places where they have power. And who provides advocacy? Parents can provide it for their children, therapists and case managers for the patients that we work with. Lawyers can be advocates, or guardian ad litems are usually the advocates for the children in the legal setting, and teachers can be advocates. This is not an exhaustive list. This is just kind of who we often think of in those advocacy roles. And then there are different kinds of advocacy. Individual, so we're advocating on behalf of one individual, or a group, including a group being a family could be a group, or a group of patients in general. So I do general advocacy work with our nurses. So I do nursing training, and I see that as advocacy work because I'm really often talking about stigma, and the stigma that healthcare systems and sometimes healthcare providers have towards individuals with substance use disorders. And oftentimes people are aware of how they might have a bias towards individuals with substance use disorders, and sometimes people are not. But patients feel that and experience that. And so we can advocate for that group of patients with substance use disorders with other groups, such as healthcare providers. And then system advocacy. And I don't know if you want to talk about kind of what you were thinking of in terms of the system.
So when it comes to the system, like what I try to do is I try to schedule what I call planning meetings. And those meetings are kind of like MDT meetings, except we don't have, like the prosecuting attorney or, anyone that's kind of potentially seeking termination. Instead, it's very much patient focused, and it's on making them comfortable with the court process and bringing all of the people involved that are kind of on their team together so we can all talk as one complete group and be on the same page. So that way, when we go to court, the patient's prepared, they're not nervous, or as nervous, I should say. And also everybody else is kind of prepared, and we're not all kind of, in our own heads, and instead we're working together and we're each bringing a piece of the puzzle. So the planning meetings are really important when you're trying to work within that system, because there are so many moving pieces and there are so many people involved in these hearings. I mean, I've been to MDTs where we've had 40 people on the call. So, you have so much going on all the time within the system. There's a lot of systems within the system. So you kind of have to bring different people from each part of that system together. And that's what the planning meetings do.
Yeah, and I imagine the planning meetings are a little bit smaller so that the patient, again, feels a little bit more comfortable talking, because any kind of meeting with 40 people, you can imagine it's not as easy to talk and speak up, or even for someone who doesn't feel like they're being stigmatized or misunderstood. And these are the general goals of advocacy. I mentioned before, really empowering people to have a voice. So the individuals we work with who are dealing with the Child Protective Services system not only don't always know what their legal rights are, but also have so much shame and guilt that they feel like they deserve to be punished sometimes, and that is very disempowering, or they've been treated that way by the people in the systems that we're working with, and they begin to believe it, and they really feel tremendously powerless. The legal system is a huge system, and so empowering them to be an advocate for themselves, as we also try and advocate for them, and also helping them identify the behaviors that they do have control over, because that's where their power lies. Sometimes we've worked with, I know Amanda and I have worked with patients who don't really have the language to advocate for themselves, so teaching them that language, and also it involves a fair amount of self-regulation. We can imagine if you have your children removed from your custody and you don't get to see them, how dysregulating that is for a parent, how angry, sad, upset a parent is in that context. And then I'm supposed to have like a calm conversation with the people who did this. Like it's a lot to expect from anyone. And so sometimes we really need to help empower the clients that we're working with to be able to sort of navigate their own emotions in the context of speaking up and having a voice. So I think that's another form of empowerment.
Yeah, Anna, I just wanted to throw this in there. Anna and I were just talking about this literally this morning. She's helping one of her patients that she's advocating for just know how to say, what to say, when to say it in an appropriate way, where she's managing her emotions on top of it. And the difference it's made in her case is significant. And we talked about how that's like, seems like such low hanging fruit, but how some people do need walk through that.
Yeah, I mean, I literally, with one client, I was like, okay, I know you're really angry. We have to validate, but you cannot curse at your CPS worker. That's not going to go well. Even though they may deserve it, and this is not right. So it's so important to validate that what you're experiencing is real and very difficult. And how do you talk in a way that people are going to take you seriously and hear you? And that's really part of that support, which is tremendous amount of validation. The CPS system does not function well. Most people at any level would say that. They are underpaid, overworked, their caseloads are enormous. They cannot meet their own quotas of visitation and phone calls and all of those things. And so they're almost kind of in crisis mode. So sometimes we'll talk with patients and clients about that. Sometimes they can hear that, sometimes they can't, because they often feel victimized by the system, and really supporting them to say, this is how it's supposed to work. It's not working like that right now, which is very difficult. And how do we kind of work within the reality that we have in front of us? Assert, so speaking up when those you represent feel that they are not able to speak. So that's what the advocate does. And that also, so for Anna in the MDT meeting with 40 people, like that takes some practice and some skill, because we also get upset and emotionally involved with some of the folks that we're advocating for, because we see things not going well, and we see the damage that can do to families, to mothers and infants, where the bonding is not taking place that's so essential for attachment, and that the process moving more slowly than it should interrupts that process. And so we can also, we need to make sure we have our emotions in check when we assert ourselves as advocates.
And I should note, 40 is not the norm. That was abnormal, just so everyone knows. Normally it's like 10 to 15, around that range, depending on how many kids and how many parents are involved, because, oftentimes you have all the kids taken and there may be, 3 fathers or so, and each one has a lawyer, each kid has a guardian ad litem. So it can get big, but that's not the norm.
Yeah. But I think even 15 is a lot of people. And if the client or the patient does not have an advocate like Anna, they feel like it is them against those other 14 people. Like nobody is on their side. Maybe their lawyer, if the lawyer has had contact with them, because sometimes patients will say, we showed up to the MDT meeting and my lawyer hadn't returned my phone calls, and so I had no idea what was really going on. So the lawyer should be an advocate, but sometimes if it's a public defender, they are also really overworked and busy and don't always return phone calls timely. So in terms of enabling, so teaching others how to advocate for themselves through active advocacy. So we model how to do that, as well as I think enabling comes through that support as well. Like, what you're doing everything you can to support your recovery. And so enabling almost encompasses that support and empowerment also to give the person the confidence to speak up for themselves. And then confide. So creating that safe space for patients to share with you what's really going on. And it can be important because a lot of times they don't feel like they can be honest, sometimes even with their treatment providers, because they know their treatment providers are mandated reporters, or that they worry about people in their group. If they report a relapse, they're going to call CPS. So we've had patients share that. And so this role of advocate can actually be even outside the formal treatment relationship, which can be helpful. Whoops, sorry, stop sharing. And then some activities involved in advocacy, affirmation and support, reaching out to all parties included. So that can include extended family. Sometimes there may be resources and support in extended family that need a little bit of engagement to figure that out. Sometimes patients feel like everybody's against them when in fact there have been some cutoffs with communication with family members, and maybe there's support there that they didn't realize. Using effective communication, so teaching clients and patients what that looks like. Again, we have to downregulate our emotions if we're going to engage in effective communication, which can be really, really challenging in the face of what's essentially a trauma, which, to have your children removed from your custody is a traumatic event. Ensuring confidentiality is really important to create that safe environment. And then also creating reports that aid individuals and highlight successes. So we often, one way that we advocate as treatment providers is we provide treatment summaries that can be given to the lawyer, given to the patient, to give to the lawyer, and then can be shared in the court setting or in MDT meetings that can really give an overview of what they're doing in treatment, urine drug screen results, as well as any other kind of report that may be relevant. And then effective advocacy involves some of these. Knowing your facts is really important because we want to be consistent in the facts that we share. And if they conflict, people begin to question our knowledge. Listening to the people we want to help. They've often not been listened to and not given a voice. So if we want to empower them to have a voice, listening is hugely important. Engaging with the community, understanding the community that they might come from, some of the barriers to accessing treatment or achieving sobriety. If everyone in the household is using substances, that will be important for us to know as we try and advocate for folks. And then building relationships with the people that we advocate for and the people the systems that they are engaged in. So building relationships with CPS workers and lawyers and judges. and then not giving up, which can sometimes be a challenge. And anything else you want to add to that?
Just that I think number 5 is the most important. I think being persistent and, kind of taking your own emotions out of it, because you have to remember the people you're working with, they've been through a lot of trauma, and sometimes they're going to take it out on you, and it's not personal. It's just, they're used to not being helped. So if they feel like, things aren't moving as quickly as they want, they don't have the tools to kind of deal with that. So you have to be patient, and you have to not give up, and you have to just keep reaching out and keep trying.
Absolutely. So common CPS issues facing pregnant and parenting individuals with substance use disorder, administration of opioids in the delivery process. So oftentimes, especially if there's a C-section, patients will be administered fentanyl. We have seen this multiple times cause problems with CPS, because if they do a urine drug screen after the delivery, there's fentanyl in their system. There may be fentanyl in the baby's system. And so it's really important to be at the ready with providing documentation about any medications that were administered during the delivery process that may show up in mom's system or the baby's system, and be proactive about that. I feel very, very grateful that we actually have as our prescriber Kelly Lemon, who's a nurse midwife. So she knows where to find those records. She knows where to who to talk to in terms of knowing if that happened. But it needs to happen pretty quickly if CPS is stepping in quickly. And then advocating around issues regarding neonatal abstinence syndrome. So both with healthcare providers, there's some advocacy here, and then CPS in terms of what it means, the diagnosis. Sometimes patients don't know how it is diagnosed, and this is in the process of changing at WVU. Jen, I don't know if it's changing with the hospital systems you work with, if you guys are using the Finnegan or Eat, Sleep, and Console to diagnose NAS.
There has been some move toward Eat, Sleep, and Console, but I know we are still using the Finnegan.
Okay. So we may see this change. There's been a lot of research recently on Eat, Sleep, and Console, which seems to be a much more simplified system of diagnosis, where you evaluate how is the baby eating and how are they sleeping, and can they be consoled as the primary symptoms of neonatal abstinence syndrome, and then what treatment looks like. So we always try and talk about neonatal abstinence syndrome before delivery, and get the patient ready for what might or may not occur. The struggle is it freaks them out, so they get really scared, and at WVU, we actually have reduced our incidence of the baby needing medication and gotten much better at all of our non-medicinal interventions to treat the disorder, so that babies don't have to stay long-term in the hospital as frequently as they did, say, 5 years ago. And a lot of the non-medicinal interventions are things that the mom or the dad, the parents can participate in, like low stimulation, low light, swaddling, and things of that nature, and skin-to-skin contact, breastfeeding. CPS notification if a patient is on medication for opioid use disorder. Again, we try and talk with patients about this in advance of delivery, that this is likely to happen. That individuals on MOUD, usually like CPS is notified, and a variety of things can happen. And it's different in every county. Sometimes nothing happens. They never hear from CPS and nothing happens. Sometimes the CPS worker will come to the hospital and visit the patient and be like, hey, everything looks fine. There's no further follow-up. Sometimes the patient, a case will be opened. Sometimes there will be removal of children, if the patient has used recently during their pregnancy or throughout their pregnancy, even if they were on medication for opioid use disorder. So all kinds of responses can occur, which, as you can imagine, leaves the patient super anxious that the worst case scenario is going to happen, but we try and reassure people that if you've been stable in treatment with no use in the last month, there is a low likelihood that CPS will be involved long-term. And then child removal, child placement, and CPS monitoring are all things that can occur that we want to try and prepare people for without causing a lot of increased anxiety, which is, sometimes a challenging balance to strike. And then helping clients specifically navigate this process requires educating them on what to expect in pregnancy, delivery, and postpartum. So I actually had a patient the other day ask about, can I proactively notify CPS in my county that I'm going to deliver a baby and I'm on medication for opioid use disorder? I'd never had anyone ask that, but she's very proactive. And so we did talk with the managers, and they said you can do that. They wouldn't open a case, obviously, but in some counties you can do that. She has not done that yet, which is fine. She's been stable throughout her pregnancy. She came in her first trimester and has been stable without any relapse. So I don't necessarily think she needs to, but it's something that we discussed. And then what happens at delivery in terms of CPS coming in possibly, or certainly being notified, and then postpartum. So educating them on what to expect. Preparing them for a variety of different things. So one of the cases we talked about, that we'll talk about in a minute, was an individual who used stimulants through most of her pregnancy. She was on medication for opioid use disorder, and she did not use any opioids, but she did use stimulants. So we tried to say and prepare her, there is a possibility that your child will be removed. So you want to make a plan. If you have any family that can take care of the child while they're not in your custody, talk with those people if you can. It's better to go in with a plan, and sometimes you can have a plan of safe care where that is written down, and folks in the hospital setting know it, and that can be shared with CPS. And the plan of safe care can include what happens in the event of child removal. Child placement, as I just talked about, visitation, if the child is removed, ongoing urine drug screens. So the whole day report, urine drug screen, have to call every day, go if your color is called. I mean, we walk people through that. We have a group-based treatment model, so often they'll hear about this process from other individuals who are currently experiencing that if they're in their group with them. Parenting, how do you parent a child that's been removed from your custody? Sometimes that really impairs bonding. And what do you do if you don't feel bonded to the child? So these are things we can also talk about, because often parents will blame themselves. What's wrong with me? I don't feel connected to this child. Well, this child was removed from your custody 3 days after they were born. It's understandable that you don't feel the same kind of connection that you might have had with a child that was not removed from your custody. And then the importance of remaining in treatment or entering treatment if they're not in treatment at the time of delivery. Action. So removing any barriers from doing what CPS asks you to do, including work, transportation, childcare, removing these barriers from accessing treatment as well, if these are barriers and other barriers. Managing emotions, that essentially the removal of a child is equal to a trauma, probably one of the most traumatic events individuals can experience, other than the death of a child. But it feels like a death, especially if patients don't have a lot of hope. And so that's the other piece that we haven't really talked about yet, but that in our roles as advocates, instilling hope is really important. And then communication, helping clients develop effective communication, as we talked about a little bit before, and Amanda mentioned, like, timing is really important. Absolutely, you should say this thing, but do you want to say it right now? or do you want to actually say it a little bit later in the meeting or in the conversation? And how do you know what the right time is, and how you're saying things and the tone and content. So really some education about effective communication is part of the advocacy process with CPS. And then some general strategies. You guys are probably familiar with all of these as ways that we can advocate for clients. And the struggle with treatment providers is this takes time, right? So how do I go to court? Which is why we are so grateful to have Anna, because this is like her job, is to be able to go to MDT meetings. And if there's any way to incorporate a position in your setting where it's someone's job to be able to have the time to go to some of these events and communicate with lawyers and CPS workers and guardian ad litems, it is highly, highly valuable. All right, I think we have some cases. Turn it over to you.
I think somebody has their hand up, Laura.
Yep, we have
Yeah,
a
I was just
question in
gonna
the
say,
chat.
I think we have some questions.
Okay, questions. Excellent. I can't, I need to stop sharing.
Yeah, stop share just for 1 second so you can see.
There we go.
There we go. Okay. Let's see. I'm gonna butcher your name. I'm real sorry. Go for it though. You know who I'm talking about.
Right. I actually had a question. I had a patient that was pretty much through going through CPS, DHHS, in regards to like amphetamine screening. They had actually taken her kids away, and apparently they were doing like daily screens for her, like getting amphetamine screening, like stimulant screening every day. And the thing that's kind of frustrating trying to advocate for her was that I don't see those labs as their provider because it was outside. And I was curious like how to do, we have our internalized labs, but when you have an external system doing labs that we can't see and we pretty much just are trusting our patients, what's the best way to like kind of like advocate for them in those situations?
So what I normally do is if I'm working with a patient, they've already signed the releases, I have their lawyers, information, so I can talk directly with their lawyer with them involved, and their lawyer will send me those screens and then I upload those to Epic. So anytime I'm working, like if you know that I'm working with your patient and you know that there's these outside screens, as long as their lawyer has provided that to me, it's always going to be uploaded into Epic.
Thank you.
You're welcome.
Then we had a question in the chat from Dr. Baltier. I see you put your camera on. If you want to go ahead and ask your question live, go ahead. You're on mute. That's it. Oh, you're still on mute there, Dr. Baltier. There you go.
There we go. I actually had to put look up the question I had. So the safe plan of care, when the family sets that up, that there's a good chance that they may have their child taken away, is a great idea. But does that have any legal standing, and how well does that work? Because I know that we're supposed to, or CPS is supposed to do prenatal safe plans of care, but the reality is it's not happening. So I think, my impression would be in our setting, it would still be pretty dependent on the caseworkers. I don't know what your experience is, Anna, and if you have any suggestions on that, because I think that is a really, and maybe all our patients should do that as a backup, because you'd never know. I mean, for me, it's still a little bit of a crapshoot. I don't know what's going to happen. And so if you have any comments on that, that'd be great.
Yeah, and I know Amanda is pretty knowledgeable on the plans of safe care. So they don't really have legal standing, Amanda, is my understanding, but they still have value.
Yeah, they still have value, and it's considered a treatment document. So when we provide a plan of safe care, and we try to do it with a lot of our patients going in, especially ones that become very anxious, that's what we try to, we empower them with the plan of safe care, and they take that in hand themselves to have that ready for them. And it's actually, a couple of years ago when we started it, it's, DHHR has said that it's actually really helpful. It helps them kind of get through that, but we've not seen it have a legal standing. It's just like any other treatment documentation that they would request.
Okay.
Yeah, and then my only comment would be if there is, like normally what I do before there's a hearing, if one of my patients has requested a progress report for court, What I'll do is I will go through their files and I'll go back, however far the court wants me to. If their last hearing was 3 months ago, I'll go back 3 months. If it was 6 months, I'll go back 6 months. And then I'll pull all the notes and I'll go through and I'll look at the plans of care. I'll look at, how they're doing, their progress, and I'll create an entire report that encompasses all of those months based on the multiple providers. And then I'll, send that to the lawyer and the patient to then turn over to the court so that they can have that for their records as well. When I've gone to court, there are some judges who will, kind of look at that and, they'll respect what it says and they'll take it into account. But then there are others who just completely will disregard. So I think it very much just depends on the judge. And, by the time I come into some cases, sometimes I'm coming in at the end and the state's already, at termination. And it's very hard at that point to kind of shift the focus of that case. It's been done, but it's definitely difficult.
Yeah, good question. Thank you. Thank you both.
I believe that was it.
Good.
Yeah.
Okay. All right, I'll share my screen. So here is our first case.
Okay, so we're going to go over 3 cases. And then I have some, after each case, we kind of have some food for thought kind of deal that, feel free to ask questions or respond with your thoughts. You can interrupt me like Laura said, that's fine, I don't mind. Okay, so case number 1 involves a single female with 2 children. They're both in foster care. She had an active addiction that led to her losing her place of residence. So she ended up houseless. She entered treatment and her screens have been negative for over a year with her treatment provider. She has had low-level positive screens at the day report center on 2 occasions. Her visitation is set to 3 supervised visits per week for 2 hours at each visit. She's missed some visits due to staffing shortages with the supervising agency. This is actually, it happens a lot because we use NIAP most of the time and they're very short-staffed. So legally, they are required to make up those visits, but it does happen that they miss visits, because of staffing shortages, as well as conflict with her work schedule. And that's another issue that a lot of patients deal with. They have to work with the foster family a lot of times and CPS. So they're not only trying to work out time with NIAP or a supervising agency, they're also trying to work out time and travel with the foster family. And then they have their work schedule. So it's really hard sometimes with the supervised visitation to kind of make that work for everyone. And a lot of visits fall through the cracks. The state is asking that her rights be terminated due to the 2 screens with the low-level positives. Next slide. Okay, so the key consideration for this case is, should the state seek termination for low-level positives on blood screens? Bearing in mind that blood screens are not considered an FDA-approved device. That would be urinalysis, which is considered the gold standard.
So any thoughts?
Yeah, so I have a question on that, because we've been dealing, and I think Laura knows this, I've been dealing with our local CPS and actually day report almost more so. So there are blood tests that are FDA approved, but my understanding is, and please correct, this is my question, I guess, are any of the tests that day report or CPS are using FDA approved, or are they just using forensic tests, which means that they're approved for police work and legal work? That's my understanding, is that that's what they're using, correct?
So they're using CLIA approved testing, which is, clinical. So
Okay.
yeah, they're not necessarily using, now in some instances, depending on, if it's the urinalysis that's going through Redwood labs, which is, that's forensic, it's fine. But if they're doing the blood screening, that's with Ken Lewis and Opans, and that would be CLIA certified.
Okay.
And
that's
the problem with those, and this is based on patient report, is they aren't necessarily following procedures like wiping people's fingers off before they take the blood sample, so they're not following forensic standards.
Yeah,
Yeah,
and
so
it
I
is
guess that-
finger prick 3-drop test. It's not venous. I should have been clear. It's not venous
Right.
blood. They're doing the
That-
finger prick.
So I guess that's where I'm confused, because CLIA, my understanding, would have to be FDA approved, because CLIA is a medical standard, isn't it? Or,
So there's
and-
devices would be like your analysis or like the screens, and this is all stuff that's been explained to me by mainly Dr. Husted, because I am
Okay, that's what I'm trying to
this is
get.
not my area of
Right.
expertise. But my understanding from what he has said is that the device that you use has to be FDA approved, and that would only be your analysis at this current time, because the sweat patches, the blood screens, none of that has actually had enough research and evidence to be used in this manner.
Right. So what I suspect is their labs are CLIA approved, but the tests that they're doing are what we call forensic, they're not FDA approved. So they're doing both probably. And so
They're
when they
using
send it,
multiple, yeah,
Right.
like they
So
use
when they're
Redwood for
sending
your
it out-
analysis and Oppians for the blood screens.
right, so when they're sending it out to whatever lab, that lab is probably an FDA lab. Maybe it is. Maybe it
Yeah,
isn't.
it can be an FDA lab,
Right.
but it would be the device, which would be, the blood screens are not, or should not be being used in
Right,
a
okay.
punitive fashion.
And so and it's very hard to contest those, which it shouldn't be, because we've actually had patients. So, we've had patients get called in, and we'll test them on the same day with our labs, and ours will be negative, theirs will be positive, but the judge doesn't care. I've actually had a judge look at me and go, "What? You give people fentanyl in labor?" And I had to explain, they just don't understand those things. And so it's really hard. I mean, for you in your position, I'm sure, to advocate against that, if it's hard for me as a physician in court to
Right.
get listened to. So I can only imagine, how difficult it is for patients and for you.
Yeah, it is extremely difficult. And because that's not my area of expertise, I'm not legally allowed to speak to, any of this in court. I'm only allowed to point out, that this person has had negative screens with our labs. I cannot, like, what I'm discussing now with you is stuff I've heard from Dr. Husted, who is an expert, but when I'm subpoenaed to court and I speak on the stand, I'm not allowed to bring any of this up.
Yeah, and just for people to know, I don't know if even Dr. Husted would be allowed, because what they've had me do is they require a toxicologist as the expert. So even if, he's an expert, but in their minds, they want a toxicologist. And so I think it's really a violation of patients' rights, clearly, but yeah. And we've had people lose their babies for these things, and almost, when we know they're not in active addiction.
Yeah,
Also
absolutely.
add Dr. Baltiera that we've had the experience that even when we've been able to secure time for a toxicologist, that the judge, they're allowed to gatekeep what evidence they're willing to consider and not willing to consider, and it's been excluded. That testimony has been excluded, and the opinions I've gotten from the legal professionals involved is it's very likely to prevent setting some kind of precedent where people can dispute the results of their drug screens. They just don't even want to go there.
Yeah, absolutely. That has been something I've noticed as well. We have had a previous case where we brought in a toxicologist. It took us a while to find one, but we were able to secure one. And we had him along with our expert from WVU, who, is Dr. Husted. And even with the testimony from the toxicologist, it was extremely difficult to persuade the judge to listen to the expert. Which, ultimately he did end up listening to him, and we were able to get reunification, which was great. But then that case was then turned into a case that could not be used as a precedent, because there was a lot of misinformation that was taken from that case and then presented a day report. And Justin Kruger, who works, is the director of day report, was put on the stand. So a lot of what he said wasn't, that was able to be used, but then what we had our experts saying to combat what he was saying was not able to be put on the record and then used in another case. So even though that judge listened, it's almost like with every judge, you're going to have to, do this education if they'll even listen.
So where we've gone at WU locally in behavioral medicine with some of the systems advocacy is to try and infiltrate the legal system and do some education with guardian ad litems, lawyers and judges. But early days on that, maybe hopefully we'll
Right.
be able to make
It almost seems like it has to be, it's a systemic problem. And, you know, until, you know, and again, I don't hate lawyers. I actually like lawyers. So, but until somebody at kind of a ACLU or public service really files something on behalf of our patients, I think we're going to keep fighting this individually. You know, so, you know, it's very frustrating because I know it doesn't matter what we do. It's a one-by-one fight. And even with having everybody except the judge and the guardian ad litem in favor of what's being said, and even the parole officers being on the patient side, it's still up to the judge completely. And there's bad information. So that's just my editorial on that. And so, but I do think it helps from our side to submit those tests, because you can say, look, there is evidence that this isn't consistent with that. They have inconsistencies in their own testing. It's positive one day and not the next, which makes no sense. Patients volunteering to test daily if the drug report is willing to do that. And so there's a lot of inconsistencies in their testing. So we even had one, I think it was the parole officer go to patient's home and said, these people have a fruit bowl. People that are in active addiction do not eat fruit. It's just a lifestyle thing. And it's kind of a silly statement, but for people that work with these patients, active addiction is very different than what we're seeing for a lot of these patients. So I'll jump off my soapbox.
No, you're absolutely correct though, in everything that you stated. You're 100% correct. You know, it's very much a systemic issue, and ultimately, you know, hopefully we'll have a systemic fix. But right now with DHHR kind of in, I don't know, restructuring, I guess is what you would call it. With them restructuring, I think ACLU and other organizations are, you know, kind of waiting to see what that looks like before they were to jump in to anything like this. So right now we're kind of stagnant, and, you know, it's just about trying to keep pushing through the barriers and represent the patients the best we can with what we've got. Okay, so moving on to case number 2, we have a male patient with a mental health issue that was untreated and an untreated alcohol use disorder. This led to a domestic violence incident where he struck his child. His wife reported him to police, and a report was filed with CPS. He voluntarily entered treatment after the incident, and he began therapy. He has maintained sobriety and is on the correct medication for his mental health disorder. His therapist notes him as stable in recovery at this time. CPS has requested there be no contact between the patient and his wife and child. The child is currently residing with the mother. Contact cannot be initiated until the protective order is modified. So normally when you have a domestic violence situation, you're going to have a protective order, and the court and CPS has to uphold what's in that order. So the only way to get around that is to modify the order before you can actually make any kind of moves forward. The child is under 14, so the state will disregard their wishes, which are currently to modify the order so they can begin therapy with their father. In the state of West Virginia code dictates that if a child is 14 and up, then the judge can take into consideration what they have to say. But if they're under 14, that's not the case. The patient's wife is committed to family therapy as well, even though the state has encouraged divorce in this case. The state was really kind of pushing for her to file for separation and anticipated a divorce was likely. However, she was really strong in advocating for family therapy. So this case kind of sheds light on the question of, should children under 14 have their wishes considered by the courts? Anyone have any thoughts on that?
Well, so that was a big part of my job in a former life. I did forensic work before coming to the med school. And so I think clearly it's important to at least gauge where the child is following a traumatic event. I think that it can be further traumatizing to a child to have to give repeated statements and to have their statements scrutinized by a lot of different professionals involved in these kind of cases. So there's a lot of positive and negative to having children's opinions under consideration in these kind of cases.
Yeah, and a lot of times we're seeing, you know, children that are 13, about to turn 14, and they're really frustrated. You know, they're telling their therapist that they just want to be heard. They want to write a letter. Their letters aren't being sent. You know, so I think for them, it's very frustrating. And I feel like a lot of times, you know, if they are really strong in advocating for that and they really want to be heard, I feel like, you know, we should probably listen to what they have to say. As long as it's, you know, as long as the parents are doing well, they're stable in recovery, you know, there's no safety concerns. I don't see the harm in, you know, respecting what they're saying.
I do think another issue your case brings up is kind of the, I don't know exactly how I want to word this, but when separation or divorce is, you know, considered an outcome that CPS would like to see happen in a case, it seems like there's not, like the gravity of that situation is not really taken seriously. Like you're asking these people to make this permanent decision after they're, you know, they've made a contractual obligation to one another to be together until they die. Or the idea that, oh, this kid just won't have a relationship with one of their parents for the rest of their life, that's not taken with the gravity that I think it really needs to be.
Yeah, absolutely. And I mean, we're talking about a situation where, you know, the mother did the right thing. She called the police, she got her child out of the situation. And then the father did the right thing. He got help and he got treatment for his mental health and his addiction issues. You know, so I think it would be different if this was something that there was a pattern of inconsistency, but, you know, we're talking about a situation that, you know, everybody did what they needed to do to make it a better, safer environment for the child.
And this is what makes it really hard is, you know, the system is supposed to really be there for the benefit of the child. That's what this is all about. And so in this case, you're right, people make mistakes. Everything happened. The mom was pretty brave to report this, and the system seems to be not doing what's best for the child, and even the child isn't hurt. And so I'm sure there are ways we could come up with, whether it's a written letter, whether it's a private interview with the court psychiatrist, that the child could, their wishes could be made known without the trauma of all that. And at the same time, I think it expresses the frustration that it's not consistent, the system. And there's a lot of coercion because basically what they're holding over all these families is custody of their child and seeing their children ever again. And our patients are very rightful to be afraid because they have seen it happen. And they also know it's almost, it's arbitrary. I mean, we hear in different counties, it varies and then it'll switch in a couple of years and a different county will be better and patients will have their babies there and they go back and forth. So that, you know, or this judge or that judge. So I think the system is lost. It's you know, kind of it's compass where it's going. And it's very frustrating. I'm sure you guys deal with this every day. I deal with it peripherally, but it is very frustrating with families like that, you know, how do you keep the family together, but being coerced with divorce should be their choice.
Right. And in this situation, I mean, we should have very clear standard operating procedures for these cases. It shouldn't be, you know, every county kind of doing what they want and having so much oversight and power. You know, there should be standards that are upheld. We're talking about separating families and, you know, I don't think that's something that should be done lightly.
Yeah, I think we probably don't have time for the last case. I think we can save this we can present it at another PPW ECHO would be my thought, because it's relevant to lots of the topics that are coming up.
That sounds good. Yeah, we can save it, have it in July or whenever you guys are available to do that. Appreciate Laura and Anna for presenting. Great information, great discussion from the group. Also appreciated. We've got about 2 minutes left. Our next session is going to be in July, July 10th. So be on the lookout for more information on that. If you have cases or questions or anything like that, please don't be shy. Please send them our way, and we'll make sure that they are answered or presented. And if there aren't any other questions, we can adjourn for the session.
Thank you, guys.
Thanks, everyone.
All right, everybody have a great rest of the day.
You too.
See you soon.